We'll get started in just a few minutes as the mini oral sessions are just finishing up. Well, good morning. We're going to go ahead and get started this morning on our last day of the Western Surgical meeting. I'm Margot Shoup, up here with Dr. Chuck Scoggins and Dr. Max Schmidt. And thank you everybody for staying for this really exciting last morning of presentations. Our first presentation is patients with acute lower limb ischemia continue to have significant morbidity and mortality, to be presented by Dr. Abdul Qadir Natour from Henry Ford Health.
Is it work? Okay. Again, good morning, ladies and gentlemen. I'd like to thank the association for the privilege of the floor. We have no disclosures. So acute lower limb ischemia is a highly morbid vascular condition. The reported 30-day amputation rate ranges from 6% to 30%, and early mortality rates range from 9% to 14%. The reported incidence of acute lower limb ischemia is 15 per 100,000 person years, and it comprises up to 16% of the vascular surgery workload. Until the early 80s, open surgery was the primary treatment option to manage acute lower limb ischemia. Today, endovascular management options are increasingly available. Fogarty balloon catheter was introduced in the early 70s, and it revolutionized the treatment of acute lower limb ischemia, providing significant improvement in the rates of mortality and limb loss. Fast forward 20 years later, catheter-directed thrombolysis was introduced and was another major step forward in the treatment of acute lower limb ischemia. However, it came to the price of losing precious time while reestablishing flow to the leg. Over the past decade, numerous novel endoluminal techniques were introduced, such as the hydrodynamic thrombectomy catheter, and they promised more rapid resolution of the thrombus. However, these are limited by the lack of long-term data on safety and efficacy. So the bottom line is that currently the treatment for acute lower limb ischemia is still undefined. The objective of our study was to evaluate the presentation and contemporary outcomes of acute lower limb ischemia patients at a large tertiary referral center. To do that, we ran a retrospective review of medical records for patients who presented to our tertiary care center between 2016 and 2020. We defined acute lower limb ischemia as a sudden decrease in limb perfusion that threatened limb viability and occurred within 14 days of symptom onset. We excluded traumatic cases, iatrogenic causes, and dissections. We defined open revascularization as any surgical incision used to perform revascularization. Endovascular revascularization was used if the therapy was totally percutaneous. Our primary outcomes were 30-day limb loss and 30-day mortality. Secondary outcomes were 1-year limb loss, 1-year mortality, and hospital length of stay. Cause of death was obtained from the Michigan State Death Registry, and we used univariate followed by multivariate analyses to examine the variables associated with our primary outcomes. Rutherford classification was introduced in 1997, and it's a clinical classification for acute limb ischemia that is based on physical exam findings and Doppler flow signals. It's divided into 4 stages. Stage 1, where limb is viable, not immediately threatened. Stage 2A, where limb is marginally threatened and salvageable if promptly treated. Stage 2B is a limb that is immediately threatened and salvageable with immediate revascularization. And stage 3 is a limb that is irreversibly damaged, where major tissue loss or permanent nerve damage being inevitable. So a total of 246 acute lower limb ischemia patients presented with 272 lower limbs ischemia. The mean age was 63 years. Most of our patients were male and white. Most of our patients presented with Rutherford class 2A and 2B, comprising 88% of our cohort, and 70% of our patients had thrombi as the etiology for acute lower limb ischemia. Most of our patients underwent open revascularization with 51%, followed by endovascular revascularization with 32%, and 22% of our patients required fasciotomy after the index procedure. This table illustrates the crude outcomes. The length of stay was 12 days. Our 30-day limb loss was 19%, and it increased to 35% at 1 year. At 30-day mortality, our 30-day mortality was 8%, and it increased to 18% at 1 year. And our 30-day readmission was 27%. Most of our patients died due to cardiovascular complications, with 48%, followed by oncologic causes and pulmonary causes. When looking at the univariate analysis for the predictors of 30-day limb loss, patients who were anemic, had a history of chronic kidney disease, or were diabetic were more likely to lose their limbs at 30 days. In addition, patients who presented with Rutherford class 2B and 3, and those who had 0 or 1 run-of vessel postoperatively were more likely to lose their legs at 30 days. Interestingly, patients who had emboli as the etiology for acute lower limb ischemia were less likely to lose their limbs at 30 days. When looking at the multivariate analysis for the predictors of 30-day limb loss, anemia, 0 run-of vessel, and 1 run-of vessel were significant predictors of 30-day limb loss. When looking at the univariate analysis for the predictors of 30-day mortality, patients who were anemic, had a history of chronic kidney disease, were diabetic, had hyperlipidemia or hypertension, were more likely to die at 30 days. Patients presented with Rutherford class 3, those who were treated either medically or with primary amputation, and those who had 0 or 1 run-of vessel post-intervention were more likely to die at 30 days. Again, patients presented with thrombi or emboli as the etiology for acute lower limb ischemia were less likely to die at 30 days. When looking at the multivariate analysis for the predictors of 30-day mortality, diabetes, and 0 run-of vessel were significant predictors of 30-day mortality. When comparing endovascular and open revascularization, no significant difference was seen when looking at demographics and comorbidities. Patients who underwent open revascularization were more likely to have emboli as the etiology for acute lower limb ischemia. No significant difference was seen when looking at Rutherford class, time from symptom to surgery, and number of run-of vessel postoperatively. When looking at outcomes, patients who had open revascularization had significantly higher length of stay as compared to patients who had endovascular revascularization. No significant difference was seen when looking at 30-day limb loss, 30-day mortality, 30-day readmission, 1-year limb loss, or 1-year mortality. This graph illustrates the long-term limb salvage rate, comparing the endovascular and open repair groups, and as we can notice, no significant difference was seen between the two groups. Similarly, when looking at overall survival with a mean follow-up of 2 years, no significant difference was seen when comparing endovascular and open revascularization. This graph illustrates the need for fasciotomy by Rutherford class. As we can notice, as the severity of acute limb ischemia increases, the probability that the patient would need a fasciotomy increases. When looking at the combined outcome of 30-day limb loss or mortality by Rutherford class, as you can see, as the severity of acute limb ischemia increases, the incidence of the combined outcome increases from 12% for Rutherford 1 to 91% for Rutherford 3. Similarly, when looking at the combined outcome of 1-year limb loss and mortality by Rutherford class, as the severity of acute limb ischemia increases, the incidence of the combined outcome goes up from 20% for Rutherford 1 to 91% for Rutherford 3. This table compares the outcomes of our studies to that in the published surgical literature dating back to the classic style trial in 1994. As we can notice, there is marginal change in the rate of amputation and mortality over the past 3 decades. In summary, the rates of limb loss and mortality remain high in the management of acute lower limb ischemia. The type of intervention of acute lower limb ischemia does not impact outcome as much as the severity of ischemia on presentation. Anemia and poor runoff predicted early limb loss, while diabetes and poor runoff predicted early death. Approximately 1/3 of acute lower limb ischemia patients required an extremity operation, whether in the form of fasciotomy or amputation. To conclude, there is currently no best treatment option for acute lower limb ischemia, and we still have a long way to go. Physicians caring for acute lower limb ischemia need to be able to offer both endovascular and open revascularization, as well as fasciotomy and amputation, depending on the patient's presentation and underlying disease anatomy. Thank you. Thank you. Myself and Dr. Shepard are happy to take any questions.
This discussion will be led by Dr. Ashman Soor at Spectrum Health, MSU.
Thank you, Dr. Shoup. I'd like to congratulate Dr. Natour and his colleagues from Henry Ford for a very nicely conducted study on acute lower limb ischemia management and outcomes. It's a difficult and timely topic, especially since the largest multi-center prospective randomized study conducted to compare endovascular versus open surgical revascularization in patients with chronic limb ischemia was just published yesterday in the New England Journal of Medicine. So I have 4 questions relating to this study. We found in our hospital that a significant number of our patients who presented with acute limb ischemia presented after their oral anticoagulants had been stopped for a variety of reasons, such as endoscopy, eye surgery, or tooth extraction. So how many patients in your group had this problem? And do you think that the guidelines for stopping anticoagulants should be changed? Secondly, a significant number of patients in your group, 1 in 4, had either a limb loss or death following admission. As we are constantly audited for our results, could you identify patients who should not have an attempt at revascularization, perhaps the Rutherford 3 types of patients? Thirdly, you have more limbs than patients. So how many patients had bilateral ischemia at presentation, and how many presented twice with limb ischemia in your group? And finally, how do you anticoagulate your patients after revascularization? Do you use heparin drip and long-term anticoagulants? Do you use DOACs? I didn't see in your tables or in the manuscript if any the direct oral anticoagulants were used. Again, I'd like to congratulate you on a nicely presented and nicely conducted study on a difficult topic that vascular surgeons dread. Thank you very much.
The discussion will be continued.
Hi, Doug Schroer from WashU. It's always nice to see a very good paper from my surgical alma mater, so it's great to see. And not being a vascular surgeon, I have a question that piqued my interest a little more. Somewhere in there, I thought I saw 25% of your patients got readmitted within 30 days. And I know our hospital would kill us with that. Was there a way that you could work with these patients to make sure they don't get readmitted or understand the reasons for readmission? Because I understand you're going to lose a lot of limbs and some of the other things are nature disease, but that readmission rate is something you could probably factor on. And is there do you know what was driving the readmission that maybe you could work on?
Are there any other questions from the floor? Great. So the closer will be Dr. Alexander Shepard from Henry Ford Hospital.
Thank you. And thank you, Dr. Mansour, for your reading of the manuscript and for your questions. Your first question was, how many patients had their oral anticoagulants stopped for a procedure and then presented in the interval when they were off their anticoagulants? And The answer to that question is very few. Far more common for us is patients who were on an oral anticoagulant who had it stopped for a procedure and then for whatever reason never had it restarted. So weeks, months later, they would present with an acute ischemic event. So I don't think current guidelines really need to be changed. We just need to adhere to them. Your second question is, are there any patients in whom revascularization should not be attempted? And you're absolutely right, Rutherford 3 patients. That's assuming it's a Rutherford 3 patient with advanced ischemia. Unfortunately, the Rutherford classification is a little unclear about the Rutherford 3 patients. And obviously a patient with advanced signs of ischemia, skin marbling or rigor of the calf musculature, that is a patient who needs an amputation. Patients that I'm not so sure about are the patients who present with a totally anesthetic foot with paralysis, but do not have skin marbling or modeling or rigor. We actually did, in that group of Rutherford 3 patients, there was one of those 12 patients in whom we were able to salvage a limb, and he's now 2.5 years out and still comes back to clinic. So that does highlight, however, the importance of the Rutherford classification scheme, which unfortunately is not well documented in most series in the literature on acute limb ischemia. Your third question was how many patients had bilateral ischemia, and that was 26 patients. So if a patient had to be in the study, we counted only patients with their first episode of ischemia. So if they returned with recurrent ipsilateral ischemia, they were not included in the study. And most of those patients were patients with bilateral emboli or an aortoiliac thrombosis. Your third question had to do with anticoagulation post-revascularization. Traditionally, all of our patients are on an antiplatelet and postoperatively on heparin and transition to a DOAC, sometimes warfarin, but most of the time a DOAC. Our biggest problem really is the patients who present after being on a DOAC, present with recurrent ischemia. What do you do with these patients? Because there's no good way of documenting that they are compliant with their DOAC. They say they're taking their DOAC, but you don't really know. And in those situations, we've been forced to go back to warfarin. And Dr. Schur asked about reasons for readmission. They were the typical reasons for readmission: wound complications and occasional episodes of heart failure. And yes, that is a high readmission rate, Doug, but the patient population in Detroit has not changed since your tenure there. I would have to say the one thing that nobody asked was, why have the results for treatment of acute lower limb ischemia not really improved over the years? That's really the $64,000 question for those of you in the room old enough to remember that TV show. And I think with all the advances in technology and anesthetic and critical care and risk factor modification, one would think we could do a better job with these patients. And I think really the answer is that we're dealing with an older and sicker population of patients. There are a couple of series in the literature based on administrative data sets, one looking at the national inpatient sample and another one looking at MedPAR data. Both of which confirm that the average age of patients presenting with acute limb ischemia has increased over the last 2 decades. And in addition, there's a higher incidence of diabetes, hypertension, atrial fibrillation, and chronic kidney disease. So my honest feeling here is that we have gotten better in taking care of these patients. It's just that the patients are a lot sicker today and older than they were in the past. I'd like to thank the association again for the opportunity to present this data and for the discussion. Thank you.
Thank you very much.
Thank you.
Yeah. The next paper is short-term outcomes and postoperative compliance of kidney transplant recipients and the COVID unvaccinated, to be presented by Dr. Bradley Kushner at Washington University in St. Louis.
Good morning, everybody. Thank you to the Western Surgical Association for allowing me to present here this morning. Today, I'll be presenting on postoperative compliance of kidney transplants in those who are unvaccinated. We have no relevant disclosures to report. As we all know, kidney transplantation remains the best available treatment for patients with end-stage renal disease. It involves improved quality of life for these patients and improved life years. However, organ availability remains sparse. There are over 125,000 patients that remain on the waiting list, and over 100 patients get added daily. We also know that there's a strong correlation between medication non-adherence and late rejection. Graft loss secondary to non-adherence is the predominant cause of antibody-mediated rejection and confers a 5 to 7-fold increased risk of graft loss. Therefore, in the age of poor graft availability, identifying patients who are at high risk for graft loss and noncompliance remains paramount. Unfortunately, the deceased donor kidney transplant population is also notoriously a high risk for medication non-adherence. Prior studies have shown that around 20 to 35% of patients actually fall into this category. Yet no smoking gun has been identified. Medication non-adherence is certainly a combination of socioeconomic, disease-related factors, healthcare organizational barriers, and many therapy-related factors. Often compliance is dynamic. Non-compliance can be isolated, recurrent, or repeated, and these repeated episodes lead to recurrent hospitalizations, decreased renal function, and ultimately graft loss. The COVID pandemic has offered new challenges for these patients. Transplant patients are at higher risk for severe infection owing to their chronic immunosuppression state, as well as their associated comorbidities, including age, diabetes, hypertension, and cardiovascular disease. And in the setting of safe and effective COVID vaccinations, many transplant centers have executed vaccination mandates. However, we don't really know whether these preoperative vaccination actually protects or can predict worse medication compliance in this population or predicts worse postoperative outcomes. Therefore, we set out to do a study to study two specific goals. First, we wanted to define whether vaccination status alone could present a unique risk factor for the transplant population. We also looked to evaluate if unvaccinated patients had inferior perioperative outcomes and compliance following their kidney transplant. To do this, we conducted a retrospective cohort study of all patients who underwent a deceased donor kidney transplant at a single academic medical center. We looked at patients who underwent this transplant during February 2021 to May 2022. We excluded patients who underwent a living transplant, had multi-organ transplants, i.e. kidney, liver, heart, liver, et cetera, or underwent multiple transplants during that study period. And for the sake of the study, we considered patients vaccinated if they received 1 dose or more of any of the mRNA vaccines. The primary outcome that we looked at was postoperative transplant compliance. And to do so, we looked at the average and total missed clinic appointments in the postoperative period, as well as the number of post-discharge subtherapeutic tacrolimus troughs. Our secondary outcomes included short-term patient outcomes, such as length of stay, readmission rates, delayed graft function, graft failure, and ICU admissions. 301 total patients met study criteria. The average age of our population was roughly 57. 40% were female, and on average, patients spent 2.5 years on dialysis. Of our 301 patients, 78% were vaccinated. The cohort demographics were actually quite similar. The only major difference between the two groups was in terms of age, in which the non-vaccinated cohort was statistically younger, as one might expect, as compared to the vaccinated group. Race, gender, transplant history, days on dialysis, BMI, and hemoglobin A1C were all similar. The only independent factor on multivariable analysis that was associated with vaccination status was age. Odds ratio was 2.1 for this. Looking at the short-term patient outcomes between the two cohorts, we found that they had a pretty similar length of stay, readmission rate, delayed graft function, and graft failure rate. The major difference was in terms of ICU admissions, where the non-vaccinated cohort had a threefold increase in terms of ICU admissions as compared to those who were vaccinated. Where we saw the major difference between the two groups was in terms of postoperative compliance. The non-vaccinated cohort had an increased number of average clinic visits missed, and non-vaccinated patients missed 3 or more of their clinic visits nearly 50% of the time, as compared to only 0.25% of those who are vaccinated. Additionally, the non-vaccinated group has statistically greater number of average subtherapeutic tacrolimus troughs in the postoperative period, more than double that of the vaccinated group. And here's just another graphical way of looking at that data. There was a strong trend in the unvaccinated group to patients having greater than 1, 2, 3, 5, and 10 subtherapeutic tacrolimus troughs in the postoperative period. Several important takeaways from this study were identified. First, patient compliance post-kidney transplant remains an issue, regardless of vaccination status. 2, unvaccinated patients had worse postoperative medication compliance. And lastly, short-term patient outcomes were similar, regardless of vaccination status. Let's take these a little bit into more depth. Patient compliance post-kidney transplant remains an issue. We know this to be true. In our population alone, 23% had 5 or more subtherapeutic tacrolimus troughs. 30% missed 3 or more scheduled clinic appointments. All of this taken together suggests that our current screening strategies for patient compliance is imperfect. If we want to ensure better graft long-term survival, we need to do better. We also found that unvaccinated patients had worse postoperative compliance. They had a greater number of subtherapeutic tacrolimus troughs, a greater total number of missed clinic appointments, and the only independently associated characteristic with vaccination status was age. While short-term patient outcomes were similar between the two groups, we hypothesized that the difference in compliance that we just talked about might actually hint at a long-term difference in graft survival if this data was taken and carried out long-term. By characterizing adherence profiles early on, we may actually be able to help prevent the multiplication of non-adherent episodes in the future. And we hypothesize that vaccination status may actually be used as a marker for poor compliance to flag patients who are at risk. Several important questions remain. First, do patients' compliance in the short term lead to higher graft loss in the future? Should transplant centers transplant patients who are non-vaccinated? And lastly, maybe more challenging and ethically speaking, does the violation of patient autonomy with vaccination mandates outweigh the increased overall public health benefit from the transplantation of all patients? Thank you very much. Be happy to take any questions at this time.
Thank you. This discussion will be led by Erin Maynard at Oregon Health Sciences University. Dr. Maynard.
Thank you to the Western Surgical for the opportunity to discuss this paper, and Drs. Kushner, Wellen, and colleagues for providing the manuscript in such a timely fashion. Some of the best I've ever seen, actually. It is well known to everyone in this room that the demand for organs to help patients in end organ failure outweighs the supply, and transplant professionals are obligated to be good stewards of a scarce resource by promoting allocation to those with the highest likelihood of benefit, while balancing concerns of infringement on an individual's decision-making. Most importantly, we need to make sure that we're not further disadvantaging certain patient populations who are otherwise already disproportionately referred, evaluated, and waitlisted for transplant. This is an issue many transplant centers are facing. It's been hours of discussion in our own personal transplant COVID task force. Multiple studies have shown increased rates of vaccine hesitancy. And while vaccine adherence has been used as a surrogate marker for compliance, the data to support this in the adult population is actually very scarce. So I commend you for your team for this work. My questions are as follows. Our biggest concern is noncompliance is the allograft loss. Does your institution utilize AlloSure or surveillance biopsies? And if so, have you examined the rates of subclinical rejection in these two patient populations? Do you use a standardized psychosocial score such as the SIPAT? And are you considering utilizing COVID non-vaccination status in addition to marginal candidates to deny listing to these patients? And the third, which is part of your additional questions, is are you currently accepting COVID positive donors, which we're seeing more and more frequently in your non-vaccinated patients?
Thank you. Any other questions from the floor? Dr. Brazo?
Harkening back to our Noni Lowry oration, I wonder if you have a little bit more information on the patients come from, and is the non-vaccinated status, is that a choice, an active choice that the patients have made, or were they unable to receive the vaccine because whatever the system factors are that made them unable to receive the vaccine?
Dr. Jerkovich?
Really interesting paper and nicely presented. Thank you. Summarize, you're using non-vaccination status as a surrogate for non-compliance. I'm wondering if you thought about other factors that may predict non-compliance as well. I mean, vaccine status, we may be fortunate, may not be with us forever, but non-compliance is likely to be with us forever. And so what other factors might be good predictors of non-compliance?
Thank you. Any other questions?
Yeah, very nicely presented. I was just curious, are you currently transplanting COVID positive patients based on their CT value? Is there a certain cutoff that you're using above which or below which you're transplanting COVID positive patients?
Can you please state your name and where you're from?
Oh, yeah. Dr. Natur from Henry Ford.
Any other questions from the floor? This will be discussed by Dr. Jason Wellen from Washington University in St. Louis.
Thank you. I'd like to thank Dr. Maynard for reviewing the manuscript and for those insightful questions, as well as the rest of the membership. With your question, do we perform surveillance biopsies on our kidneys? We generally perform over 300 kidneys at Washington University in St. Louis. So due to logistics and manpower, as well as some data that has shown that surveillance biopsies often don't result in improved outcomes, we are not currently performing surveillance biopsies, only biopsies for cause. If someone comes in with graft dysfunction. However, we are currently performing new technology called AlloSure that you refer to, which is really cell-free DNA measurements in our kidney recipients. So we do those approximately 6 months during the first year, and it's thought to be able to capture subclinical rejection. So we are performing AlloSure. However, we did not look at that in this manuscript, but it's an excellent point. I think something we need to look at is, are these people starting to show some damage to these kidneys from their noncompliance? An additional question was, are we using any sort of standardized score for evaluating psychosocial risk for our transplant recipients? We are not using the SIPAT score at the moment. We have other measurements that we do to try to capture noncompliance. As you can see, none of them are perfect. We have our social work team reach out to their dialysis units to get a pretty detailed record of have they been missing dialysis sessions? Do they show up late? Do they pull off the machine early? History of drug usage, et cetera. But we're not currently using the SIPAT score, but it may be something that we need to embark on as we see the number of high noncompliance rates. An additional question was, are we accepting COVID positive donors for non-vaccinated patients? You know, the COVID positive donors has been very fluid. You know, we're learning a lot as we all start to accept more and more organs. We are certainly accepting COVID positive solid organ transplants right now. We confer with our infectious disease team to see, you know, what we want to do about it long term, depending on if our recipient is vaccinated or non-vaccinated. As you can see, we're transplanting non-vaccinated recipients. Some other questions Dr. Brazo had asked. Patients, is it their choice to be non-vaccinated, or is there an active choice from our patients, or is this non-availability of getting the vaccination? It's been the patient's choice. We've always, you know, we are strongly encouraging our patients to get the vaccine, and we have very creative ways to get these patients the vaccine, depending on where they live. But these are patients, for whatever reasons, have made the active choice to not be vaccinated, despite our very strong encouragement to be vaccinated. An additional question was, are we using been using non-vaccination status as a surrogate for non-compliance? Are there other factors? I just mentioned we're using time on, pulling off the dialysis machine early, not showing up for dialysis sessions, looking at their blood pressure, their hemoglobin A1Cs, how well they follow with their other physicians. And we do a deep dive into some of those points to try to capture as a surrogate for non-compliance. There's other programs that have used drug usage, marijuana usage, other things you can sort of use. It's been documented in some manuscripts about some of those histories as far as contributing or giving a window into their compliance rates. And the last question was from Henry Ford: are we using COVID positive organs? We are using COVID positive organs. It's a moving curve right now with infectious diseases. Did they die from COVID, or did they just die from a car accident and they happen to test positive for COVID? So every COVID positive patient is different than the next one, but we certainly are using COVID positive organs. Thank you.
Great. Thank you very much. Our next paper is lobectomy with unilateral prophylactic central neck dissection for papillary thyroid cancer, usage and outcomes in the United States, to be presented by Dr. Julia Green from St. John's Cancer Institute.
Thank you. Quite the mouthful of a title. Thank you for allowing us to present our work today. Press the green button. Which one? Press the green button. Okay, thank you. We have no disclosures. Thyroid cancer is the most rapidly increasing cancer in the United States, with papillary thyroid cancer representing about 90% of cases. With overall excellent survival rates, optimal surgical strategy for low-risk papillary thyroid cancers remains debatable. While we know that lymph node metastases are common, the effect on survival is likely small. And although the data is limited, prophylactic central neck dissection has been suggested to improve disease-specific survival, local recurrence, and postoperative thyroglobulin levels. Recommendations for lobectomy versus total thyroidectomy allow for significant variability in practice patterns. Recent studies have evaluated the trends and outcomes of various surgical strategies, including lobectomy and thyroidectomy. However, data is lacking involving the results of prophylactic neck dissections. Therefore, we chose to evaluate trends in the management of outcomes of localized papillary thyroid cancer in a large contemporary cohort with specific focus on those receiving the prophylactic central neck dissections. Our learning objectives can be seen here: to review the current trends in treatment of papillary thyroid cancer, as well as to evaluate more comprehensively the effects of these treatment patterns on outcomes. First, I will review our study design and basic patient characteristics. We identified patients greater than or equal to 18 years of age in the clinically node-negative primary PTC patients from 2000 to 2018 in the SEER database. We excluded all histologies except for PTC, follicular variants, and high-risk subtypes, and those without diagnostic confirmation or those without defined operative procedures. We also excluded grade 4 disease, T4 disease, N1B, and M1 disease, and those missing nodal evaluations. Finally, we excluded those with thyroidectomy and central neck alone and those with lobectomy and RAI alone. This left us with a final study cohort of about 136,000 patients, of which 110,000 were primary cancer patients. The cohort was evaluated for trends over time and reported first course of treatment and for differences in survival. Patients were divided into the treatment groups seen here: thyroid lobectomy with central neck, total thyroidectomy with RAI and central neck, total thyroidectomy with RAI without central neck, and total thyroidectomy alone. Of note, we based on the review of our literature, we defined central neck dissection as the removal of greater than 5 or more lymph nodes. Of 110,000 patients with early stage PTC, the majority were female and less than 55 years of age. 65% of patients were found to be white non-Hispanic, and 61% were diagnosed in the latter half of the study period. PTC represented 67% of cases, with follicular variant presenting 32% and high-risk subtypes presenting 1%. The majority of patients within the population had T1 disease, with unknown T stage being the next most frequent. More than half of patients were pathologically N0 disease. When analyzing our data, we looked at treatment patterns among various groups. Treatment did not differ based on gender, with the majority of both genders receiving some iteration of total thyroidectomy, whether or not that included a central neck or RAI. And 1% or less received lobectomy with central neck, which happens to be our population of interest. Treatments were largely similar across age groups, though older adults were slightly less likely to receive a prophylactic central neck dissection. About half of our T2 and T3 patients underwent total thyroidectomy with RAI, while only a quarter of the T1 patients did. Conversely, almost half of our T1 patients underwent total thyroidectomy alone, and a quarter of those underwent with T2 and T3 disease had total thyroidectomy alone. About 3 times as many T1 patients underwent lobectomy alone when compared with those with T2 or T3 tumors. PTC made up about 67% of patients and is seen here in blue. About a third received total thyroidectomy and alone, and another third received total thyroidectomy and RAI. Excuse me. Sorry, I went forward too far. Sorry about that. Follicular variant seen here in the light green made up about a third of patients with similar treatment patterns. Only a third received total thyroidectomy alone, a third total thyroidectomy with RAI, and about a third, with only 7% receiving total thyroidectomy, RAI, and central neck. Only 15% received lobectomy alone. And lastly, our high-risk subtypes made up only 1% of the population, with the most common treatment at 43% being total thyroidectomy with RAI. A quarter received total thyroidectomy, RAI, and central neck, and a quarter with total thyroidectomy alone. Unifocal disease was treated with thyroidectomy alone about 43% of the time, and multifocal disease only about a third of the time. And as you can see here, patients with multifocal disease were much less likely to undergo lobectomy at 6.5% versus almost 20% with unifocal disease. When looking at trends in treatment over time, we see that throughout the study period, about 38% received total thyroidectomy alone, 34% total thyroidectomy and RAI, and 15% with total thyroidectomy and RAI and central neck. Another 15 received lobectomy alone, and about 1% received a lobectomy with prophylactic central neck dissection. Overall rates of lobectomy and prophylactic central neck were relatively stable at 1%. Less than 1% for lobectomy and central neck, and 15% for lobectomy alone. Total thyroidectomy with RAI decreased, while total thyroidectomy with RAI and central neck increased. And when analyzed as a whole, a decrease in the use of RAI over time was observed in total thyroidectomy patients from about 60% in the first half of the study period to 51% in the second half. On multivariate analysis, factors associated with the receipt of lobectomy plus prophylactic neck dissection were diagnosis after 2009, younger age, white non-Hispanic race, clinically T1 disease, solitary tumor focus. Similarly, factors associated with the receipt of lobectomy irrespective of their lymphadenectomy status included the aforementioned factors, as well as American Indian and Alaskan Native race, male gender, and follicular variant pathology. On multivariate analysis, improved survival was associated with diagnosis after 2009. No differences were seen between surgical treatment groups. However, male gender, Black race, and Hispanic ethnicity were associated with decreased survival, as were high-risk subtypes and T2, T3 disease status. No significance in overall survival was noted between surgical treatment groups when analyzed with propensity score weighting and Cox proportional hazards regressions. But they were noted when analyzed by T stage, age, and high-risk histologic subtypes. Unfortunately, comparisons within our main cohort of interest, the lobectomy with prophylactic central neck, were difficult to discern given the lack of overall numbers and events. Disease-specific survival was noted to be improved in total thyroidectomy, lobectomy alone and total thyroidectomy alone groups, as well as those diagnosed after 2009. Decreased disease-specific survival was also associated with male gender, Black race, Hispanic ethnicity, and high-risk histologic subtypes, as well as those with T2 and T3 disease. Adjusted disease-specific survival analysis favored thyroidectomy and total thyroidectomy alone. Differences in disease-specific survival were noted when analyzed by age, with that favoring those without central neck dissection. No differences were noted when analyzed by T stage. Here you can see the limitations of our study. It is a retrospective review and has the limitations of such, as well as those associated with database analyses. Low mortality rates limited our survival analysis, particularly the disease-specific survival, and low overall numbers limited our study as well. With ever-evolving practice guidelines in the treatment of differentiated thyroid cancer, we observed a trend towards decreasing utilization of RAI. However, rates of lobectomy alone and lobectomy with prophylactic central neck remain stable, representing the minority of patients. For low-risk tumors, the extent of surgery does not show a significant correlation with overall survival. We suspect that the improved disease-specific survival noted in lobectomy and thyroidectomy groups is likely representative of a selection bias inherent in retrospective studies and our inability to control for factors including extrathyroidal extension, intraoperative assessment of disease, and operative techniques and completion of surgery. When in reality, the surgical treatments are probably likely equivalent. The extent of surgery should therefore reflect that which has the lowest recurrence rate while minimizing complications and optimizing quality of life. Thank you.
Thank you. This discussion will be led off by Dr. Stephen DeYoung at Loyola University.
Thank you, Dr. Shoup. And I want to thank the Western Surgical Association for the privilege of discussing this paper. I want to also thank the authors for sending me a copy of their manuscript well in advance of this meeting. I want to congratulate Dr. Green and Dr. Goldfarb and their colleagues for a very nicely presented and important study using the SEER database to examine the use and utility of thyroid lobectomy for and central cervical lymph node dissection for the treatment of low-risk papillary thyroid cancer. There's general agreement that central lymph node dissection should be added to thyroidectomy in patients with clinically positive cervical lymph node metastasis. Performing prophylactic central cervical lymph node dissection, however, in these patients is more controversial, especially when overall survival and disease-specific survival in this study was not affected by the type of resection in their low-risk patients. The authors acknowledge the study limitations of large database retrospective analysis, and that despite increasing utilization in the second time interval of the analysis, the thyroid lobectomy plus cervical lymph node dissection group is still the smallest patient cohort in their analysis. I have a few questions. A discussion of prophylactic central cervical lymph node dissection during thyroidectomy must include a discussion of morbidity. Could you detect an increase in morbidity, particularly recurrent nerve injury or seroma chyloma in patients with lobectomy plus central cervical lymph node dissection versus patients who had lobectomy alone? Defined as removing greater than 5 lymph nodes. And should this be done by low volume thyroid surgeons in the community with limited experience and limited case volume? Second, could you determine in your study if patients with negative central cervical lymph node metastasis after lobectomy were more likely to avoid treatment with radioactive iodine ablation as a potential benefit for adding central cervical lymph node dissection to the procedure? Third, how do you advise patients treated after lobectomy with central cervical lymph node dissection when the final pathology confirms unsuspected lymph node metastasis in their prophylactic cervical lymph node dissection? Should they have completion thyroidectomy followed by radioactive iodine ablation, observation with surveillance, contralateral lobe ablation with radioactive iodine, or another treatment? And finally, as we appear to be moving from total thyroidectomy to lobectomy as adequate treatment for selected low-risk patients, it seems almost counterintuitive to add central lymph node dissection to these patients with clinically negative central cervical lymph nodes. How do you reconcile this with your findings as patients in this study treated with lobectomy or total thyroidectomy without central cervical lymph node dissection actually had better overall survival and disease-specific survival? I want to thank you again for the privilege of discussing your work, and I enjoyed reviewing this manuscript very much. I recommend it highly to the membership after it's published. Thank you.
Thank you. Any other questions from the floor? This will be closed. Oh, go ahead. Sorry.
Sam Snyder from Edinburgh, Texas. I really enjoyed your study and really we need more, just like what you're doing. Your study group was very small, so I'm really not surprised by your results. I have a comment and a question. My comment is that clinically node negative is really dependent on ultrasound preoperatively. And I can tell you from experience, I do surgeon performed ultrasound. The radiology performed ultrasounds are highly inaccurate. So your study group may be very inaccurate in terms of what is clinically node negative. And so it requires a really accurate ultrasound. I frequently disagree with radiology when it comes to that preoperative evaluation. And what we're really talking about is your disease-specific survival is the same, but we're interested in disease-free survival or recurrence. Were you able to get any information on your patient study groups, whether or not there was recurrence? And a second issue would be whether or not they have BRAF. And was that included into your analysis? Were you able to get that information? Because we know that BRAF positive tumors have a higher risk for lymph node metastasis. Thank you.
Thank you. And this will be closed by Dr. Melanie Goldfarb at St. John's Cancer Institute.
Thank you, Dr. Shoup and the Western, for an opportunity to present our work today. I'm going to try to answer everybody's questions, some of which are very easy because I can't answer them. So the SEER database, it's really great for, I think, trying to do provocative questions and going to the next level of research, but it does not give us information on morbidity. So we don't know about complications. That's something the NISQIP, endocrine now has SESQIP, so maybe some of those databases can help us. It does not have recurrence-free survival. Doesn't answer the question that Dr. DeYoung came up with, which was great, of does doing the central neck prevent them from getting the total and getting the RAI? Those two questions possibly could be answered by doing a linkage with some of the hospital claims data that there have been some papers done either by some thyroid groups or other groups where you can link some of the databases, and maybe we actually could answer some of those questions, which would require a nice grant to do that. But possibly in those. To answer some of Dr. DeYoung's other questions, what do I think about telling low volume versus high volume surgeons to do this? I think him and I agree. I think this is, if you're a high volume surgeon, doing a prophylactic central neck without many complications is kind of our standard. So I think it's great for us to do, but I would not advocate for the surgeon in the community who does a handful of these a year to just start adding them in. And to go back to Dr. Snyder's question about ultrasound, you're preaching to the choir. I do all my own ultrasounds. Dr. Green, my other fellow, Dr. Milgram, who's here, they know I don't agree with radiology most of the time, or I should say half of the time. And so I do think it's really important, whether you as the surgeon or you have a trusted radiologist to do it, does really impact, are they really clinically no negative? But even so, doing the ultrasound when the thyroid's in there, you miss a lot of cervical disease. So I don't think even ultrasound is 100% accurate if somebody's clinically no negative. So great question, agreed, but I don't think we're quite there. What do I tell patients if I do the central neck nodes and based on the results, what do I tell them? So if I have patients where I take out 5, 6, 7 nodes and they all come back positive, those handful of patients, which I think is more rare, I will probably tell them to go get a small dose of radioactive iodine. But if I do a good prophylactic central neck and I get, let's say, 2 out of 5, 6, 7 nodes positive, there's not really extra thyroidal extension or whatever. I feel like I've now really proved that the patient is low risk, that they're not full of nodal disease, and B, I've cleaned out what's really there. So I'm very happy with that, and they're good and done. So that's how I manage the discussion with those patients. And the last question of as we're, how do we reconcile the findings of improve survival with the lobe and total and the central neck, as Dr. Green mentioned. We don't really think this is improved survival. We more want to would talk about this as a non-inferiority study or an equivalent study. So I think the prophylactic central neck for us endocrine surgeons is a philosophical debate in many ways until there is some way to get some better data. But it's definitely at least equivalent. And I do think that we are cleaning out disease and getting a more accurate representation of patients' disease from when we do it. All right.
All right. Thank you very much. Great paper. Our next paper is higher rates of recurrence and worse quality of life in obese patients undergoing inguinal hernia repair, to be presented by Dr. Mikhail Attar from North Shore University Health System.
I'd like to thank the Western and the moderators for giving us a chance to present. Here are our disclosures. Obesity is a major health issue, both in the United States and worldwide, and has been increasing in prevalence. Most organizations define obesity as a BMI or body mass index over 30. Obesity has a variable influence on gastrointestinal surgery outcomes. There's a lot of prior publications that have shown that obese patients suffer from longer operative times, increased blood loss, and an increased rate of short-term complications. Groin hernias are common, and inguinal hernia repair is one of the most commonly performed operations by general surgeons. There have been a couple of prior publications looking at obesity and inguinal hernia repair with conflicting results, some showing no effect on outcomes and others identifying high BMI as a risk factor for recurrence. There's not much data currently on health-related quality of outcomes in obese patients undergoing inguinal hernia repair. So we sought to answer the question, are there differences in perioperative outcomes, quality of life, and incidence of long-term recurrence between obese and non-obese patients undergoing inguinal hernia repair via all approaches, open, laparoscopic, and robotic? We conducted a retrospective review of a prospectively maintained hernia database, comparing patients with a BMI greater than or equal to 30 to those with a BMI less than 30. Health-related quality of life was measured using two scales. The first was the Surgical Outcomes Measurement System, or the SOMS. This is a surgery-specific questionnaire that looks at 7 domains: pain impact, pain quality, pain on a visual analog scale, fatigue, physical functioning, body image, and satisfaction. The other scale that we used was the Carolinas Comfort Scale, or the CCS. This is a hernia-specific survey instrument that has questions in 3 different domains: mesh sensation, pain, and movement limitations. And this scale is measured on a 5-point Likert type scale. In terms of our statistical analyses, patient and clinical characteristics outcomes were summarized using mean with standard deviation, median with interquartile range, and frequency with percentage. Difference between obese and non-obese patients were looked at with independent sample t-tests and chi-square tests. And quality of life at different time points postoperatively was compared using the Wilcoxon rank sum and chi-square tests. Here are results. This table shows patient and operative characteristics and this has been stratified by obesity as well as surgical approach. We had a total of 5,575 total patients in our cohort. And as you can see, the majority of those patients underwent laparoscopic repair. We found a significant difference in the open and laparoscopic group in terms of age. As expected, we found that there was a significant difference in all groups for their BMI. In the laparoscopic group, we found that a greater percentage of patients suffered from diabetes, and this was statistically significant. And in both the laparoscopic and robotic group, there were a greater proportion of patients in a higher ASA class. In terms of operative outcomes, we found that regardless of whether the patient underwent unilateral or bilateral repair, operative times were longer in obese patients in the open and laparoscopic group. Looking at postoperative outcomes, we found that in the open and laparoscopic group, patients who were obese took narcotics for significantly longer. And in the laparoscopic group, the return to activities of daily living in obese patients was longer, mirroring that of the time in the open group. There were no differences in 30-day ED visit or readmission rates. However, looking at complications, there was a statistically increased risk of surgical site infection in obese laparoscopic patients. Looking at other outcomes, there was no differences in seroma, hematoma, urinary retention, or suprapubic tenderness at follow-up. However, as you can see here, there is a long-term risk increased in the obese patients of recurrence, 4.5% versus 1% in the open group, and 4.5% versus 2.3% in the laparoscopic group. These are our health-related quality of life results. As you can see on the SOMs, these are the laparoscopic patients specifically, at multiple time points, including preoperatively, patients that are obese have a worse quality of life as measured on this scale. This is true for pain impact, pain quality, pain as measured on a visual analog scale, and fatigue. Looking at the Carolinas Comfort Scale results, as you can see here for the laparoscopic patients, at different time points post-operatively, up to 2 years, obese patients report worse quality of life. This is also true in the robotic group. However, we did not find this to be statistically significant due to low reporting. In comparing our results with others in the literature, multiple authors have found no differences in postoperative complications when comparing obese and normal weight patients, although in their studies, their patient numbers were lower than ours. However, in a population-based study, a Swedish study, they compared underweight, normal weight, and obese patients and found both underweight and obese patients had a greater risk for postoperative complications. In one study in which they looked at 1,047 laparoscopic totally extraperitoneal repairs, the authors found that a BMI greater than 30 was a risk factor for recurrence in both univariate and multivariate analysis. There are a number of limitations to our study. This was a retrospective study design, and selection bias certainly played a role. Patients were lost to follow-up. There's a higher percent of patients, as you saw in the obese groups, that had a higher comorbidities that may be playing a role in worse outcomes and postoperatively, as well as recurrence. We do have low survey response rates at later time points, especially going past 1 year. And all the surgeons in our group are minimally invasive surgeons, so this study may not be applicable to the general community. In conclusion, we found that obese patients are at risk for experiencing worse outcomes after open and minimally invasive inguinal hernia repair. We found that they had higher rates of surgical site infections postoperatively, a higher risk of long-term recurrence, and worse health-related quality of life. Since obesity is a modifiable risk factor, we suggest that emphasis be placed on weight loss and comorbidity management prior to inguinal hernia repair, especially in patients who are having elective repair, in which hernia repair can be safely delayed. Thank you.
This discussion will be led by Dr. Saju Joseph from Touro University of Nevada.
Thank you, Dr. Shoup and Western Surgical. And thank you to the authors for not only providing me the manuscript very early, but allowing me to review this. The authors presented an 11-year experience in a very large hernia database, and I congratulate them on their work. This is actually very important and very needed. A couple of questions that I have. One, you have a larger proportion of obese patients undergoing robotic surgery in your numbers. Obviously, it is what I would call a newer evolving technique. Does that represent merely a evolution of technique, or is there a preference to robotic surgery in these obese patients? In our practice and many others, I think I would call it an evolution of practice. Number two, when you look at recurrence rates, it's a very important piece of information. However, I feel as though, and I think more and more we're seeing in obese patients, that it is important to look at other hernia occurrences, not just recurrence of the hernia that you fixed, but rather patient getting a right inguinal hernia repair who shows up with an umbilical hernia or a left inguinal hernia as merely a systemic problem of abdominal hypertension and the weakness in the abdominal wall occurring elsewhere. So I wanted to get your opinion on what your thoughts were on that. Finally, and you made a mention to it, should prehabilitation be a hallmark piece of hernia repair in all obese patients? Diabetic patients, clearly A1C management has been shown to be very important. Should we be approaching these patients in a different way for anyone that is not in a kind of urgent, emergent fashion? And how do you suggest we do that? Thank you.
Thank you, Dr. Madura.
Thank you. Congratulations. Great piece of work. Great presentation. I guess my first caution would be that if you took hernia out of the equation on quality of life and compared non-obese to obese individuals, you would have very similar graphs to what you showed. So I'm not sure how that really relates to the hernia repair. Obese patients routinely report that they have higher rates of fatigue, mobility issues, chronic pain, those types of things. So it'd be interesting. I don't know if it's even possible to do surveys in a non-hernia population, but I think those have been done and you might want to look up those references. I think my other observation and question for you is if you look at recurrence rates, not only in the obese individuals, but in the non-obese individuals, they favored in your study open repairs. You had about half as many, I would think it was 1% versus 2.3% recurrence rates in open versus your laparoscopic groups. So I'm wondering, the question then is, what are your recommendations in an obese population coming in for inguinal hernia repair? Should the approach laparoscopic versus open come into play?
Yeah, that was going to be my question. Did you look at your outcomes by procedure type, comparing the laparoscopic to robotic to the open procedure? And what is the right approach? You know, I'm a naive breast surgeon, haven't done hernia repairs in many years, so I'm kind of curious to see what your thoughts are on that.
Dr. Ledgerwood?
Anna Ledgerwood, Detroit. Did you look at smoking, the incidence of smoking between the two groups? I might have missed that.
Any other questions from the floor? Great. Well, this will be closed by Dr. Stephen Haggerty from North Shore.
Good morning, everybody. I'd like to thank the Western for allowing us to present this work, and thank you, Dr. Seju, and the rest of the crowd for these questions. As for the first question about steering patients toward the robotic repair, we did have a higher BMI in our robot group. And I would say that out of our minimally invasive 4 surgeons, 2 of us do robotic abdominal wall reconstruction and robotic inguinal hernia repairs. And we do prefer the robotic for morbidly obese patients, although there's no data to support that. In fact, we presented our own comparative study at the American Hernia Society comparing open, laparoscopic, and robotic in obese patients. Not surprisingly, we found that the minimally invasive group had shorter return to activities of daily living, less narcotic use, and better quality of life compared to open. But the complications were the same, and the numbers were too small to compare robotic versus laparoscopic. Anecdotally, I think that the robot is preferred in obese patients. We do totally extraperitoneal laparoscopic repair, and in obese, the space can be very limited, and also visualization can be impaired by the fat. The transabdominal approach allows a wider opening of the peritoneum and dissection. The robot allows more precise dissection to fully expose the myopectoneal orifice. It also allows suturing of the defect, which is another study that we're putting together to see if suturing the defect before placing mesh will actually lower recurrence rates. We would need a very large, multi-center trial to sort this out. As far as the second question, our current database does not allow capturing other hernias in patients that we have done a hernia repair on. I do think that's an interesting subject, as obesity is shown to increase risk of ventral and incisional hernias. However, it has not been shown to increase the risk of inguinal hernia formation. In fact, one study showed that the obese patients had a lower risk of inguinal hernias. So that's an interesting topic for the future. I think prehabilitation is very important and a hot topic in abdominal wall reconstruction. It has been shown to decrease complications such as surgical site infection in ventral hernia repair, specifically weight loss, smoking cessation, and control of diabetes. So, we have not studied that in the inguinal population, and I think some of our data makes it compelling that prehabilitation should be looked at in this population where the surgery is generally elective and patients can be optimized. So the quality of life survey that we use, the SOMS we've used for many years, it is surgery specific, unlike the SF-36. And it relates to the period around the surgery. The patients did have worse pre-op SOMS, and it then worsened at each time point along the way. The Carolina Comfort Scale was only post-operative comparison and did show a significant difference between the obese and non-obese, but I think that's an interesting point. And again, maybe the prehabilitation of the obese can help their quality of life as well. This data did not look at differences between laparoscopic, open, and robotic with regards to recurrence. Our prior study did look at that, and there were no statistical differences between the two in the obese. So I think that we're still not sure whether the open or robotic or laparoscopic should be preferred in the obese. And finally, we did not analyze smoking in this data set. Thank you very much for allowing us to present.
Thank you very much. The last paper of this session is gastric bypass is associated with increases in all short-term postoperative complications compared to sleeve gastrectomy in U.S. veterans. A VASQUIP analysis to be presented by Dr. Salsa Tonelli at Loyola University Medical Center.
Thank you. Hello, my name is Chelsea Tonelli. I'm a general surgery resident at Loyola University Medical Center. Thank you to the Western Surgical Association for the opportunity to present our work. These are our disclosures. Obesity is a significant cause of morbidity in the US, and bariatric surgery has proven to be effective in treating both weight loss and improvement of comorbid disease. The two most commonly performed procedures are the Roux-en-Y gastric bypass and vertical sleeve gastrectomy. The Roux-en-Y gastric bypass is a more well-established procedure and acts to influence weight loss through restrictive and malabsorptive methods. Compared to the newer vertical sleeve gastrectomy, which acts to restrict oral intake, the bypass is a more technically difficult procedure. In our Veterans Health Administration system, excess weight and obesity affects a significant portion of the veteran population, estimated to be about 78%, or a total of 6.6 million veterans. The veteran population is distinct in that patients are older, predominantly male, and with greater comorbid disease compared to the general population. The system is also unique in that it is the largest single-payer healthcare system in the US. Despite these factors, there are lower rates of bariatric surgery in the VA system,
about 36 times lower than the general population amongst at-risk groups. This led our team to investigate the trends in bariatric surgery in the VA. We also wanted to evaluate postoperative outcomes in the VA over time and between the two most predominant procedures, Roux-en-Y gastric bypass and vertical sleeve gastrectomy. We therefore performed a VASCOP analysis of Roux-en-Y gastric bypass and vertical sleeve gastrectomy cases performed from 2010 to 2021. The VASCOP dataset is unique when evaluating bariatric procedures in that these procedures are included in a mandatory fashion, meaning that every case performed within the VA will be included in VASCOP. Other bariatric procedures such as laparoscopic band and duodenal switch were excluded from this analysis. To explore the progression over time, we divided our study period into two cohorts, 2010 to 2015 and 2016 to 2021. Our statistical analysis included an assessment of procedure rates over time, number of facilities performing bariatric surgery over the study period, and evaluation of postoperative outcomes between procedures using multivariable logistic regression, as well as one-to-one propensity score matching. Our primary outcome of interest was occurrence of a postoperative complication within 30 days. To further delineate the complications that were occurring, we classified the included outcomes based on whether they were surgical or non-surgical in nature. Surgical complications included those such as a significant bleed, return to the operating room, or surgical site infection. Non-surgical complications included cardiac arrest, pneumonia, and urinary tract, amongst others. We also classified the postoperative outcomes based on Clavien-Dindo complication grade, with examples seen here. We defined a severe complication as a Clavien-Dindo class of 3 or greater. Finally, to estimate the rate of anastomotic leak, patients that experience an organ-space surgical site infection, deep wound infection, or wound dehiscence were combined. We identified 4,193 patients that underwent a bariatric procedure during our study period, of which 1,120 underwent a gastric bypass and 3,073 underwent a sleeve gastrectomy. Patients were similar in age and BMI. Oh no, we're a little off. There was a higher proportion of white patients who underwent a gastric bypass, and patients who underwent a gastric bypass had higher ASA classes as well. At the start of our study period, there were similar proportions of gastric bypass and sleeve gastrectomy performed, but over time, sleeve gastrectomy became the dominant approach. There was a steady increase throughout the study in the numbers of cases performed in the VA system, with the exception of 2020 and 2021 as a result of the COVID pandemic. We also explored whether the VA was adding additional sites during our study, which it continued to do throughout. There were 14 sites performing bariatric surgery in 2010 compared to 22 in 2021. To evaluate if there were changes in clinical practice that may have driven the increase in case numbers, we evaluated the patient characteristics by study period. Compared to the early study period, the later period had younger patients, more female patients, and higher proportion of Black patients. There were also more patients with lower ASA classes undergoing bariatric surgery. To evaluate if our patient outcomes improved during the study, we compared our selective outcomes between study periods. There was a significant improvement in complication rate in the later years, and this was evident in both surgical and non-surgical complications. The length of procedures and length of stay also decreased over the study period. With this in mind, the two procedure types were compared to evaluate postoperative outcomes. Unsurprisingly, the sleeve gastrectomy was significantly faster by 90 minutes. The sleeve cases also had a lower rate of complications, even when exploring whether they were surgical or non-surgical in nature. There were also lower rates of anastomotic leaks and severe complications in the sleeve group. Given that these procedures are inherently different, we adjusted for patient and case factors such as age, body mass index, tobacco use, ASA class, and the time period to better understand the role of the procedure in experiencing a postoperative outcome. The sleeve gastrectomy cases experience a 70% decrease in the likelihood of a postoperative complication. As seen in our univariate analysis, the likelihood of experiencing a complication decreased significantly over our study period. Additional multivariable logistic regressions were performed for secondary outcomes of interest as seen here, also adjusted for patient and case characteristics. In all of the outcomes listed, the sleeve gastrectomy cases had significantly lower likelihood of complications. Finally, we propensity score matched the sleeve gastrectomy cases to the gastric bypass cases based on the factors listed below. There were 1,105 cases identified from each arm. After matching was completed, there were significantly lower rates of complications, whether surgical or non-surgical, in the sleeve group. Rates of anastomotic leak were slower in the sleeve group as well, but did not reach statistical significance. There are limitations to our analysis. These include difficulty with generalizability to the general population, given the unique setup of the VA system and the patient cohort. We do not currently have information related to long-term weight loss following these procedures, but are planning to explore this in a future work. Finally, there is a selection bias related to the reasons a specific procedure was chosen that we cannot adjust for given the use of a large database such as this. Despite these limitations, we believe our analysis provides an important exploration of this current system of bariatric surgery in the VA, our nation's largest single payer system. The number of bariatric procedures performed in the VA is increasing, although there remains significant room for ongoing growth and expansion of these programs. Vertical sleeve gastrectomy is the predominant operation performed in the VA currently. While the overall rates of complications were low, sleeve gastrectomy cases had significantly lower rates of complications compared to gastric bypass. Thank you to my co-authors for their support in this project and to the Western Surgical Association for the opportunity to present.
This time as invited discussant, Dr. Stephen Haggerty from North Shore.
I'd like to thank the Western Surgical Association for inviting me to discuss this presentation from Loyola University, Chicago, comparing gastric bypass and sleeve gastrectomy in the Veterans Affairs Health System. I'd like to thank the authors for providing me with a manuscript in advance. This was a very nicely written paper that is both novel and interesting. You noted that obesity continues to grow as a national health problem and that 75% of the patients enrolled in the VA health system are overweight or obese. Bariatric surgery case volumes continue to rise across the country, and the sleeve has become the most common operation performed, representing about 60% of all bariatric operations performed in 2019. The ratio of sleeve to bypass has changed similarly in the VA health system, with the sleeve making up 79% of your cohort in 2019. You analyzed a large database to identify trends in short-term outcomes after bariatric surgery. And your cohort is a relatively high-risk patients, as you stated, almost 70% men, 86% ASA class 3, 6% active smokers. Your primary outcome variable was 30-day complications, and you found that the vertical sleeve gastrectomy group had lower rates of overall complications, surgical and non-surgical complications, and severe complications related to the Roux-en-Y gastric bypass, and that the sleeve leak rates were significantly lower than the bypass. So you concluded that in the veteran population, sleeve gastrectomy may be the procedure of choice in acceptable candidates due to the significantly decreased risk of complications compared to Roux-en-Y gastric bypass. This is a pretty strong statement considering your data is at a high risk for selection and reporting bias. In addition, surgeon experience has been shown to have a significant effect on complications after bariatric surgery. Surgeons who are past the learning curve, which is higher for gastric bypass than sleeve gastrectomy, have lower complications. So my first question is, do you have any data on the experience or case volumes of the surgeons included in your analysis? My second question is, you note the bariatric case volumes in the VA system were significantly higher throughout your time periods. Can you explain how the VA was expanded this besides adding extra sites? Did they, for instance, change the criteria to make it easier for patients to get approved? Or did they increase groups covered such as pediatric patients or the elderly? Finally, can you explain the significantly higher rate of non-surgery complications after gastric bypass versus sleeve gastrectomy? Thank you for your excellent work.
Thank you.
Thank you. Dr. Madura.
James Madura, Phoenix. First of all, as a learning moment, the American Society of Metabolic Bariatric Surgery and the International Federation for the Society of Obesity have recently come out to revise the guidelines for bariatric surgery recommendations from 40 without medical problems to 35 with medical problems, and they've revised that to 35 and 30 for the same respective populations. That's obviously not going to go through the insurance companies yet, but those are going to be replacing the NIH guidelines from 1991, and that's based on all of our information. So we may be seeing even larger volumes of bariatric surgery performed, even though our patient, hopefully obesity population is staying relatively stable. You know, I'm old enough to say this is a third wave of bariatric comparisons with the exact same type of presentations. First, it was vertical sleeve gastrectomy versus gastric bypass, and it was less invasive and it wasn't as intrusive and didn't involve messing with the intestines, and so we should do vertical banded gastroplasties, and so that took off. And those people that believed in gastric bypasses did gastric bypasses, and then the vertical sleeve gastrectomy went away, and we saw the lap band was less invasive, it was reversible and adjustable. Lap band took off, and now nobody does any lap bands. And it's based on data like this, which is retrospective, highly selection bias, tainted with experience and surgeon selection, as Steve had pointed out. So I'd be very cautious about using this in guiding patient selection or operation selection in the future. And I think what I'm seeing in my personal practice is I do 3 or 4 sleeve revisions a week now because of reflux and because of strictures or food intolerance as they go on from year 2, 3, 4, 5 down the road. So I would just like your comment on how, same thing, how is surgeon selection bias affecting this operation selection?
Thank you. Any other questions from the floor? This paper will be closed by Dr. Marshall Baker from Loyola University.
Thank you. Thank you to the Western for the opportunity to close this discussion. My disclosure is that I'm not a bariatric surgeon, but I was involved in the analytics, so I'll kind of give you my view on it, which I think is kind of biased in the direction of Dr. Madura's comments. But you know, to take the questions in order, Dr. Haggerty, thanks for looking at the paper and giving us insightful comments. Your questions are spot on as typical. And on question number 1 about surgeon experience, so the kind of the goal of this study was to just kind of get us started in the VA analysis of bariatric experience in the VA, and it's a VASQUIP-based study, so we haven't kind of tapped into really the wealth that's in the VA yet. So the VA has a data warehouse which is incredibly deep and will bring forth information which I think will answer a lot of the questions that have been raised. The VASQUIP data set by itself doesn't really track information on surgeon experience. We can get some data on center experience, but when we go into the EDW, we will be able to, I think, bring out some of those numbers and be able to better adjust for that. I will say that the VA has a very finicky, persnickety, difficult approval process that you have to go through, which is, I think, honestly harder than in some ways what it sounds like private hospitals are going through to get their bariatric centers of excellence launched. So you have to have very robust, support structures, nutrition. The MOVE program is very well established. And the surgeons that are able to get approval to bring the bariatric programs online are generally very experienced people who are well trained and do a high volume of bariatric procedures. In terms of how the expansion is happening, there haven't been really, I think, any specific changes in who is qualifying for bariatric surgery within the VA system, but there's been sort of a slow organic process of trying to increase the number of centers that are doing it. And I think that has been slow in part because just getting programs launched at the VA is a logistic and technical challenge. But I think we'll continue to see growth there slowly over time. The high rates of non-operative or high rates of non-surgical complications. In the Roux-en-Y gastric bypass cohort, I think is a very good question. We think it's probably in part related to the length of the operation, 90 minutes longer than the sleeves. We did match the cohorts for BMI, so there's technically not bigger, more comorbid disease kind of scenarios. We think it's probably related to length of operation, but not really able to get more granular than we already have. To adjust to just follow on Dr. Madura's comments. I mean, as a non-bariatric surgeon, the growth in the sleeve has been really alarming to me too. And I look at it and everything I see about it, it seems to indicate that you lose less weight, you have more weight regain, you have more complications in terms of reflux disease. And I think part of the reason to investigate this from my viewpoint is it'd be nice to bring some of that data forward in a bigger informatics-based kind of analysis. And I think we will be able to do that with the data warehouse data that's going to come next, which means we ought to be able to report PPI use. We ought to be able to report some more probably natural language processing based analysis of what symptoms of reflux are like. And I think we'll be able to report BMI and weight regain, which you can't even do, as far as I understand, in the MBA-SQUIP data set that the college maintains. So I think the next iteration of the study will be something that really answers your questions, and I expect we'll answer it in the opposite direction than what we're showing you here, which would probably be a good thing to do.
Thank you very much. And this concludes this session. Thanks everybody for great papers. We're going to move on in just a couple minutes to the final session of the meeting.